بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. I'm Dr. الرحمن كنعان, Advanced Gastroenterology, Hepatology. It's my pleasure today to discuss with you and to present updated management of the upper GI bleeding for the people who is in the gastroenterology field. I will discuss the updated about the ACG guideline, and I will make a little bit comments on the Baveno 6 recommendation in upper GI bleeding. So to start with the definition of upper GI bleeding, we know that nowadays we classified the GI bleeding to three categories: upper, middle, and lower. The upper GI bleeding is the bleeding which coming above ligament of tretis. Any lesion above this ligament, we call it upper GI bleeding. Below this ligament to the terminal ileum, we call it middle GI bleeding, and the colonic bleeding is the lower GI bleeding. Why this is important? Because every type of this category has a special approach and a special kind of investigation. Okay? So this is regarding the definition of the GI bleeding. This is the ligamentum of tretis, and as I said, this is the pancreas, and this is the second part of the duodenum. This is the first and second part, and that one is the ligamentum of tretis. You don't have pointer? So, then the second issue I would like to raise is about the etiology of the upper GI bleeding. Still, the commonest cause of upper GI bleeding is the peptic ulcer disease. It's not esophageal varices. It's worldwide. The most common cause of upper GI bleeding, about more than 50%, 54% is secondary to peptic ulcer disease. Okay? And this diagram will give you the clue that about 65% of the causes of upper GI bleeding is related to the peptic ulcer disease or peptic ulcer erosion, and the white color, which is 19%, others like Mullary Weiss or any abnormal lesion, secondary to sepsis, secondary to DIC, and we have still a few percent, which is the green, which is erosion. The esophageal varices is represent here, especially in our country, the third or the fourth causes of upper GI bleeding. Okay? Then the most important thing in the GI bleeding is the management of the GI bleeding. And the management here, I will categorize it to the medical and non-medical, because we have medical management and we have endoscopic management of upper GI bleeding. The most important thing, not even in the upper GI bleeding, in every diseases, the most important thing that we have to be able to stratify the risk for our patient, because by risk stratification of our patient, we can categorize the patient, and then we can, by the stratified our patient, we can know which level of care we can give our patient. We can know that which kind of treatment of management we can offer for that patient. Shall you will treat this patient in ER? Because there is some cases of upper GI bleeding, I discharge him from the ER. There is some people just I let them to stay for 24 hours. There is some people I have to admit them to ICU. This is depend on how much we are knowledgeable enough to stratify the risk of the patient with upper GI bleeding. And we have a lot of score, we will discuss this issue. So why we need to stratify every disease, not only the upper GI bleeding, because as I told you, we have to know which care of level that we have to give for our patient. We have to know the timing of endoscopy, because the medical people, they calling us as a gastroenterology or endoscopist, please come to do endoscopy now. There is no upper GIT endoscopy for now. You have at least by book 12 hours. By book, by the guideline, I have a right to come within 12 hours to resuscitate patient with upper GI bleeding, to do endoscopy up to 24 hours. And here we categorize the patient based on the score on high risk patient or low risk patient. High risk patient, I have to come within 12 hours. There is an Egyptian paper, which is very interesting paper, that patient with esophageal varices, you may come within 6 hours. In high risk patient, and the bleeding is secondary to esophageal varices, there is an Egyptian paper, which is a very interesting paper, that we have to come for those kind of people within 6 hours. But the American guideline, and even in Baveno 6 guideline, they recommend that the immediate upper GI endoscopy should be within 12 hours. Why? Because we have to start to restate your patient. Sometimes your patient come with hemoglobin 6 or 4 or 5. How come I will do endoscopy for a patient who is unstable with hemoglobin 5? How come I will sedate him? Because most of the gastroenterology, they did the endoscopy alone, without anesthesiologist. Most of them. We sedate the patient conscious sedation. So if you give me dazolam or clotidine or fentanyl or whatever the type of sedation, the blood pressure will go down. Okay, so usually we have to resuscitate your patient to give him blood, to correct the coagulation. So you have to admit him to ICU. Then after that we can come to do endoscopy. So the most important thing in this slide, the resuscitation, which is ABCs and upper GI bleeding, and the most important point in resuscitation is the cannula. Without cannula, you will lose your patient in the ER because the management depends on how much IV fluid or blood you give for that patient and how much medication you want to give. And all our medication in upper GI bleeding, whatever the upper GI bleeding is secondary to peptic ulcer disease or secondary to esophageal varices, you have to give some IV medication, right? So the IV cannula is very important as ABCs. So coarse airway is important. And regarding the airway, in the resuscitation of patients, they recommend to intubate the patient in two conditions. If upper GIT with outer the level of consciousness, and this is recommended by the European, by the Bavino guideline, they said any upper GI bleeding with outer the level of consciousness, you have to intubate the patient. Okay? The American, what they are saying about upper GI bleeding, they said, if you go by the endoscopy and you find spurting blood vessels, this is an indication, go back and do intubation for your patient. So these are the American, they recommend intubation if there is spurting, if there is active bleeding, and the European, they said only if there is altered level of consciousness. And commonly, the altered level of consciousness with upper GI bleeding, if you take the scenario as a one unit, usually this is related to hepatic encephalopathy, and this is secondary to chronic liver disease. So the role of intubation in upper GI bleeding, as I told you, two things. Either there is altered level of consciousness, or if you did endoscopy and during your work you find that there is spurting active bleeding. Okay? And then the risk assessment, we will talk about this by details, pre-endoscopy management, endoscopic management, pharmacological, and even post-discharge. What is the plan before you discharge your patient? So the initial assessment and the risk stratification, hemodynamical status should be assessed immediately. Open the presentation and the resuscitative measure begin as needed. ABCs, this is usually should be started by the ER doctors. They have to start the ABCs for this patient. And as I said, the most important thing, you have to find cannula. Remember, when you resuscitate the airway, breathing, and the circulation, you have to take a history, an examination. And they teach me in MRCP examination that the most important sign by which you can differentiate between upper GI bleeding secondary to peptic ulcer disease from the upper GI bleeding secondary to esophageal varices is splenomegaly. So please, when you are going to evaluate your patient in the ER, touch the tummy and look for splenomegaly. If the splenomegaly is there, this is most likely related to portal hypertension. Most likely, it's not a pathognomonic. But this is one of the signs that may help you. Plus or minus, if you find a sign of chronic liver disease, ascites, this is going with portal hypertension, esophageal varices bleeding. But remember, in the exam, splenomegaly, one of the very important signs. Okay? Plus or minus, as I said, look for the sign and the stigmata of chronic liver disease. So resuscitation is very important, should be done in the ER before you calling the endoscopist for endoscopy management. The resuscitation, as we said, you have to look for the vital sign, which is the most important thing in the vital sign is the heart rate and the blood pressure. The level of consciousness, as we said, if the patient is indicated to be intubated or not. The postural hypotension is very important. This is indicate that there is going bleeding. This is one of the bad signs. The dryness of the mucous membrane, neck veins, and the urine outputs. And here there is a very important issue, especially in elderly. Now we are in Hajj, in Umrah time, and most of my patients, which I receive them with upper GI bleeding, are Egyptian patients. Now I have in King Abdulaziz more than 10 patients, Egyptian, and to be honest, they came with late stage. I have 3 patients of them, they have HCC, hepatocellular carcinoma, 3 of them, and they are young, to be honest. I have 2 ladies, their ages 30 and 30 plus with HCC. The concern here that when you have a patient with upper GI bleeding and you start to assess for the dehydration, the most sensitive sign in elderly to assess dehydration is dryness of the armpit. The most sensitive sign to assess the dryness in elderly is the dryness of the armpit. Never ever you will find the dryness of the armpit for any patient, for anyone who is elderly. Usually it's not like wet, right? So if it is dry in elderly, this is a sign of severe dehydration. Okay? So obtain CBC, electrolyte to assess the hemoglobin, to see the renal failure, to look for the electrolyte, because a lot of patients, they have They are chronic liver disease, so you may have thrombocytopenia, you may have hyperkalemia secondary to some medication, especially spironolactone. So electrolyte is very important, coagulation is very important, blood type and blood grouping cross-matching is very important. Remember one thing, the INR, it doesn't reflect the liver status. The INR should be 5 or 3 and the liver status still is preserved. So usually in patients with chronic liver disease, there is many factors you have to look for to assess the liver function. We have a score, we'll over this score. But remember, for example, a lot of people, they are scared to do acetic tap for patients with INR 2 or 2.5. No, please do it. There is no relation between diagnostic acetic tap and the INR. The only contraindication of acetic tap in abnormal INR is 2 conditions. Either your patient on DIC or you have which we call hyperfibrinolytic syndrome. This is the only two contraindication to do acetic tap. Please don't look to the INR. I'm talking about diagnostic acetic tap. Okay? But if the INR is high, which make you worry, look for the other parameter of DIC. Look for the peripheral blood film. Look to the fibrinogen level, FDB. So if you have a DIC, it's contraindication. Stop here. Otherwise, there is no relation. Please do acetic tap. For any patient who presented with new ascites, tense ascites, altered the level of consciousness, abnormality in the liver function test in a patient with chronic liver disease. These are the indications that we have to rule SBB in those kind of people. Okay? So these are the most important in the resuscitative measures. And after that, yeah, interesting. This is very interesting because American people, they believe on something and the European people, they believe in other issues. We have 2 ways of blood transfusion. We have restrictive and we have liberal. Some people, they believe that you have to give too much blood. And I'm against them. Because the American guideline, they said that patient if the hemoglobin, your goal in patient with upper GI bleeding to maintain the hemoglobin from 7 to 8, except. The rule for any patient with upper GI bleeding, you have to maintain the hemoglobin from 7 to 8, except. Patient elderly with ischemic heart disease, please keep the hemoglobin 9 and above. Any patient with active upper GI bleeding, you told me, Dr. Kanahan, the hemoglobin is 9, but there is active upper GI bleeding, please give them blood. So these are the 2 conditions in which that you have to give blood. This is which we call the restrictive strategy. Restrictive strategy, if the hemoglobin is 7 or 8 and the patient is hemodynamically stable, please don't be in hurry to give blood. Why? Why restrictive blood transfusion is a good option for those kind of people, especially the upper GI bleeding secondary esophageal varices, because they found that if you give blood, you will increase the mortality. You will increase the recurrence of bleeding because you will increase the hydrostatic pressure of the esophageal varices, and this will enhance the bleeding. So please, if the hemoglobin for patient with upper GI bleeding 7 to 8 without active bleeding, it's not an elderly, there is no any sign of ischemic heart disease, keep the hemoglobin. Ask a blood transfusion for standby, but don't give the blood, please. Okay? So as I said, regarding the blood transfusion, we have 2 strategies, either liberal, there is some people they believe that you have to give and to maintain the hemoglobin 10 and above, and there is some people they said, which is the American, they said you have to keep the hemoglobin from 7 to 8, and this is the restrictive strategy. Okay? This is the important thing about the blood transfusion. We talk about the intubation, upper GI bleeding, as I said, alter the level of consciousness, or there is active bleeding. So if you believe the active bleeding in the ER, and the definition of active bleeding, to be honest, should be endoscopically defined. It's not a matter of how much you present with upper GI bleeding, and even if the hemodynamically unstable. They said that if you go in by endoscopy and you find spurting blood vessels, you go back, intubate your patient, and then endoscopy your patient, scope your patient again. This is the 2 indication that when you will have to put the tube for the patient. The risk stratification, which is, I believe it is very important, because as I said, the risk stratification, it will give us a clue when I have to come to do the patient. And the second issue, which level of care I have to give the patient. Shall I have, because there is some patients, as I said before, that we treat them from the ER, and I let them to go home without endoscopy. This is if a Blatch-4 score is 0. So we have 2 scores. to decide to assess the risk stratification in patient with upper GI bleeding, I have two scores. I have recall score. This is طبعا pre-endoscopy recall score. And regarding the recall score, interesting that we have clinical recall score and we have complete recall score. Clinical recall score depends on the age, blood pressure, and the heart rate. And they found any patient, his age more than 80 with upper GI bleeding, I will give him 3 scores. Any patient less than 60, I will give them 0. So the recall score, clinically very simple. It depends on the age. Less than 60, from 60 to 79, and 80 and above. 0, 1, and you will give 2, not 3, sorry. You will give 2. For recall score, up to 80, you will give 2. So then the heart rate, more than 100, less than 100. More than 100, they will give 1, less than 100, they will give 0. Then the blood pressure, if the systolic blood pressure more than 90 or less than 90, I will give 1. So this is simple clinically. Then the last parameter is the comorbidity. The most dangerous comorbidity is the renal failure, heart failure, or liver failure. I will give the patient 3. Otherwise, anything, I will give 1. So this is which we call it clinical recall score. Complete recall, it depends on the endoscopy finding. And endoscopy, we will talk about this in first score because we divide it in high risk or low risk finding. And this is very important, this high risk, because we can predict the recurrence of bleeding for those kind of people. We will talk about the endoscopy finding in the endoscopy part. But usually, recall score is very simple. Yani when you call me from the ER and you told me the recall 3 and above, this patient, I have to admit him to ICU. Any patient with positive recall, the difference between recall scoring and Blatchford score, because Blatchford is more difficult, but it's very sensitive and specific. Blatchford, I use it when we are doubt between the medical and the gastro that this is it hematemesis or hemoptysis? Really there is cough-gram or nothing? I will go to Blatchford score. Blatchford score, it depends on the blood urea, if it is more than 32. It depends on the hemoglobin in the female less than 12, in the male less than 13. It depends on the heart rate and blood pressure. It depends on the presence of melena, dizziness, heart failure, or renal failure. Based on that, the total score of Blatchford is 25. And the total score principally for recall score is 7. If you have 3 and above in recall, this patient high risk, I have to admit him to ICU. Any patient with Blatchford more than 9, I have to admit him to ICU. Blatchford 0, I discharge him from ER. يعني يجي patient only by history of cough-gram. But I calculate the hemoglobin is okay. His blood urea is okay, heart rate, blood pressure, no dizziness, no melena, no renal failure, nothing. I discharge him from the ER. Okay, so Blatchford, I use him for either I accept the patient or not. But the recall to assess, يعني recall استخدمه, I use it when I have a frank upper GI bleeding. I use the recall score. Okay, I will tell you another updated score which is very simple. More than recall, more than Blatchford score. Recently, this score, it generated a rise on the March 2016. We call it AIMS more than 65. I think everybody know CARE more than 65. CARE more than 65 is the score used to assess pneumonia. I think you know it, right? So this is CARE, there is AIMS, A-M-I-S more than 65, AIMS, HADF. AIMS more than 65, this is the recent score which is applicable and very simple score to assess upper GI bleeding in the ER. A for albumin. If the albumin is less than 3.5, I will give 1 point. M, the mental status. If the mental status deteriorated or abnormal, I will give 1. I for the INR. If the INR more than 1.5. S for systolic blood pressure less than 90. So AIMS, albumin, mental status, INR, and systolic blood pressure. The age more than 65. لو الخمسة positive for you, the recurrence, the risk of rebleeding is 33%. If all are negative, the 5, the percent of bleeding is 0.3%. 0.03%. 3%. So if I have 0 of these 5, of this AIMS, more than 65, no, 0.03%. 0.03%. If I have 5, I have 33%. So it's simple to memorize it. This is one of very simple score. You can use it to assess the patient pre-endoscopy, either recall, and we know what is the indication of recall. We talk about Blatchford, and I talked recently about the AIMS score. This is the recall score, as I mentioned. And this is the Blatchford score, and I told you it's usually to be used when you would like to discharge the patient, when you are doubt about the symptoms of upper GI bleeding. This is the Blatchford score. But remember, scoring system, it doesn't, because there is case by case, you find some cases not applicable. Okay? So the most important thing is the vital sign for your patient. If the vital sign make you worry, whatever, and if I get history of coffee ground, but the patient is shocked, patient is tachycardia, I bring him for endoscopy. So remember, issue that score, it may help you to guide you, but you have to be conscious, because there is a one principle I learned it from outside, that guideline guided blind people. We have to have our own guideline. You have to tailor your patient based on the data and based on the epidemiology of your patient in this country, for example. But you have to know the guideline, you have to keep the guideline in your mind, but sometimes case by case is different from the other case. Okay? Okay, pre-endoscopy, how we can prepare the patient for endoscopy. Because to be honest, we are in misery life when we do endoscopy for patients with active upper GI bleeding. Don't think that the endoscopist, he's like a hero, he will see. The most problem in managing the upper GI bleeding is localization of the GI bleeding. This is the most difficult. And when the patient came to us, it came with the clot, stomach full of blood. So how can we look for the source of bleeding? One of the recommendation is you giving prokinetic in the form of erythromycin 250 milligram 30 to 1 hour before the procedure. Actually, the erythromycin is not available in the private hospital. It's not available in the governmental hospital. It's not available. The guideline, they said, you have to use erythromycin 250. But to be honest, I learned from one of Egyptian figures, he's Mustafa Hassanin, if you heard about this name, he said that why you not use erythromycin IV? And despite the recommendation is erythromycin IV. But Prof. Mustafa Hassanin, one of the figures, Egyptian professor in upper GI bleeding, he's a figure, this patient. And to be honest, we do respect the Egyptian doctors in the gastroenterology because they have good experience with upper GI bleeding. How much they see many cases per year, how many cases they are doing endoscopy per year for esophageal varices. They are more expertise than us, to be honest. So usually in one of his lecture, it's not in the guideline, he said that erythromycin, in his study, in his research, he used erythromycin in preparing patients for endoscopy. But there is a very important trick here. Please, for the medical specialist, before you decide to give prokinetic erythromycin, you have to do one thing, which is ECG. Please, before you giving prokinetic, you have to give ECG. You have to do ECG looking for the prolongation of QT interval. Should be more than, if it is more than 2 large square, prokinetic is absolutely contraindicated. Don't give, please, because it may lead to QT interval and the complication of that arrhythmia. And then the other important issue is the BBI pre-endoscopy. Does BBI pre-endoscopy decrease the mortality, the morbidity, the hospitalization? No. There is difference between the pre-endoscopy BBI and post-endoscopy BBI. The pre-endoscopy BBI doesn't have any role in decreasing mortality, morbidity, or hospitalization. But what is the benefit of giving BBI pre-endoscopy is to downstage the high sign of bleeding. يعني بتخلي sign من high risk to low risk. This is the only function of the BBI pre-endoscopy. Okay? But post-endoscopy, it reflects. After I manage endoscopically, then I give BBI, it play a major role in decreasing mortality, morbidity, and hospitalization, and even the recurrence of bleeding. So this is the role of BBI. And usually we are giving stat 8 milligram, and then we can put the patient on 80 infusion stat, and you put your patient 80 milligram per hour infusion for 3 days. This is the way how we giving the. As we said, this is the erythromycin and the role of erythromycin to cleansing the stomach from the clot and from the blood, preparing for endoscopy. We talk about the BBI and the role of BBI. As we said, the pre-endoscopy doesn't improve anything except downstage the high risk sign to low risk sign. Okay, down staging as I said. Okay, regarding the gastric lavage, and at the end of our talk, I would like to share with you your experience about the NG tube in treating upper GI bleeding, because in the past, they use NG tube for suction and insertion and injection ice water in the bust. But nowadays there is no rule. So please, the rule of NG tube in upper GI bleeding, if you are doubt about the lower GI bleeding that it's coming from up. This is the only condition. But nowadays there is no rule to aspiration or to do ice or these things. It's not recommended in the guideline anymore. So the NG tube, it's not recommended except if you have patient with massive lower GI bleeding and you would like to confirm, you would like to help yourself, in spite it is not sensitive 100%. Because the study shows that NG tube, you put NG tube and you aspirate bile, and you may have lower upper GI bleeding and duodenal ulcer down. So it's not neither specific, neither sensitive. The only recommendation in American guideline, you would like to use it especially if you would like to differentiate that the source of hematochezia is upper, not lower. Okay? So this is about, now let us to talk about, as we said, that the timing of endoscopy is very important based on the risk stratification. At least 12 hours in high-risk patient. If he's elderly with active bleeding, hemodynamic and unstable, you have to come within 12 hours. If the patient is stable, there is upper GI bleeding, but there is no sign of severity based on the scoring, you can come within 24 hours. So now, as we said, the timing, let us to speak about the management. How we are using the endoscopy in stopping the bleeding. Let us to divide it either secondary to esophageal varices or secondary to peptic ulcer disease. And I would like to send a message here that 30% of esophageal varices, they presented with peptic ulcer bleeding. 30%. A lot of patients, they go in with esophageal varices, but the bleeding coming from the gastric or duodenal ulcer. 30% of esophageal varices, chronic liver disease, they presented with bleeding from the peptic ulcer. Okay? So what is the management of esophageal varices by endoscopy? The first guideline is banding. Okay? So regarding the sclerotherapy, nowadays they reduce it. The first line treatment of esophageal varices esophageal varices bleeding is banding. What is the indication you prefer sclerotherapy more than banding? In one condition. If the bleeding is like a hell and you cannot localize the varices, then what you are going to do? You will try to inject based on the anatomical, because you don't see anything. And believe me, there is some situation that you can't localize where is the varices it is. Wherever you wash, if you give the patient erythromycin, you will have a good view. But actually, as I said, we don't have erythromycin here. So we are fighting with the clots and with the blood. Sometimes, to be honest, I inject in the fourth quadrant and the bleeding is stopped. And then we thank the gap. If the bleeding not stops by the sclerotherapy by 5%, while using 5% etonolamine, if the 5% etonolamine is not working, I bought single-staken tube. Blackmore single-staken tube or Manitosa tube or even Lenton tube. We have 3 kinds of tube. But they are applicable in the hospital. Even here we have it. We have single-staken tube. 2 balloon, gastric balloon, esophageal balloon, 2 airway, 1 for the gastric, 1 for the esophageal varices, and another 1 for aspiration. Usually the balloon, the single-staken tube is only bridging. Should not be stay more than 24 hours because, as you know, it can lead to necrosis. You have to take it out within 24 hours. In this situation, the bleeding is stopped, everything is clear, then you can band or you can inject at that time. But you have to remember that the first indication, the first line for patient with esophageal varices is banding. And we said the sclerotherapy, we can use single-staken tube. Nowadays, the recent guideline we use by American, they put stent. And there is another indication that if the patient presented with upper GI bleeding and the MELD score more than 19, they prefer to send your patient to TIPS if there is no contraindication for TIPS. TIPS, which is intrajugular hepatic portosystemic shunt, this is one of the ways that you can reduce the portal hypertension and reduce the bleeding secondary to esophageal varices. So tips, one of the way that used to treatment upper GI bleeding, especially in patient with MELD more than 19, because in the study they found that the patient, if the MELD score is high, whenever you are going to your patient, the risk of rebleeding still is high. Okay? So this is how we manage upper GI bleeding secondary to esophageal varices. Secondary to peptic ulcer disease,